Welcome to Pediatric Case Review. Today's lecture covers Goldenhar Syndrome, also known as oculoauriculovertebral spectrum. We will explore clinical presentation, examination findings, pathophysiology, diagnostic approaches, treatment strategies, and associated complications. This comprehensive review is designed for healthcare specialists managing patients with craniofacial anomalies. Let us begin. A 3-month-old infant is referred for facial asymmetry noted since birth. The question asks, which finding is most characteristic of Goldenhar syndrome? Option A, bilateral symmetric facial features. Option B, hemifacial microsomia with preauricular skin tags. Option C, midface hypoplasia with cleft palate. Option D, macroglossia with mandibular overgrowth. The correct answer is B. Hemifacial microsomia with preauricular skin tags represents the hallmark presentation of Goldenhar syndrome. This condition features unilateral facial underdevelopment, typically affecting the right side more commonly. Preauricular skin tags and pits are pathognomonic findings. Facial asymmetry typically becomes more apparent as the child grows and develops. A newborn with hemifacial microsomia undergoes ophthalmologic evaluation. The question asks, which ocular finding is commonly associated with Goldenhar syndrome? Option A, congenital cataracts. Option B, epibulbar dermoids. Option C, retinoblastoma. Option D, primary angle closure glaucoma. Consider the classic triad of this condition. The correct answer is B. Epibulbar dermoids occur in 60 to 70% of Goldenhar syndrome cases. These benign tumors typically appear at the limbus or conjunctiva. Lipodermoids may also be present in affected patients. Epibulbar dermoids represent the ocular component of the classic oculoauriculovertebral triad that defines this syndrome. A 6-year-old child with known Goldenhar syndrome complains of neck stiffness. The question asks, which vertebral anomaly is most frequently seen in this condition? Option A, atlantoaxial instability. Option B, hemivertebrae and fused vertebrae. Option C, spina bifida occulta. Option D, spondylolisthesis. Think about the spectrum designation. The correct answer is B. Hemivertebrae and fused vertebrae occur in 30 to 60% of Goldenhar syndrome patients. The cervical spine is most commonly affected by these anomalies. These vertebral defects may cause scoliosis or torticollis. Vertebral involvement completes the oculoauriculovertebral spectrum that gives this condition its alternative name. During newborn examination, right-sided microtia is identified. The question asks, which ear abnormality pattern is typical in Goldenhar syndrome? Option A, bilateral symmetric low-set ears. Option B, unilateral microtia with oral atresia. Option C, prominent ears with normal hearing. Option D, auricular hematoma with cartilage damage. The correct answer is B. Unilateral microtia represents a classic finding in Goldenhar syndrome. External auditory canal atresia commonly accompanies the microtia. Approximately 50% of patients develop conductive hearing loss. Ossicular chain malformations frequently contribute to hearing impairment. Early audiologic assessment is essential for these patients. A 4-month-old infant presents with asymmetric crying facies. The question asks, which facial nerve finding is associated with Goldenhar syndrome? Option A, bilateral facial paralysis. Option B, unilateral facial weakness affecting lower face. Option C, trigeminal nerve palsy with corneal anesthesia. Option D, hypoglossal nerve palsy with tongue deviation. The correct answer is B. Unilateral 7th cranial nerve involvement commonly occurs in Goldenhar syndrome. This results from facial nerve hypoplasia or complete absence. The weakness affects the same side as the hemifacial microsomia. Facial nerve dysfunction may significantly impact feeding capabilities and facial expression development in affected infants. A 2-year-old child presents with feeding difficulties and speech delay. The question asks, which oral finding is frequently observed in Goldenhar syndrome? Option A, macroglossia with tongue protrusion. Option B, cleft lip and palate. Option C, ankyloglossia with restricted tongue movement. Option D, gingival hyperplasia. The correct answer is B. Cleft lip and palate occur in 15 to 20% of Goldenhar syndrome cases. Unilateral cleft is more common than bilateral presentation. High arched palate is frequently present even without frank cleft. These orofacial anomalies significantly contribute to feeding difficulties and speech development challenges. During a genetic counseling session for an affected family, the question arises, which embryologic disruption causes Goldenhar syndrome? Option A, neural crest cell migration defect. Option B, ectodermal dysplasia. Option C, mesodermal proliferation disorder. Option D, endodermal differentiation failure. Consider the structures affected. The correct answer is A. Goldenhar syndrome results from disruption of neural crest cell migration. This occurs during first and second branchial arch development. The critical period spans weeks 4 to 8 of gestation. The syndrome affects structures derived from branchial arches, explaining the characteristic craniofacial and auricular manifestations. Parents of an affected child inquire about recurrence risk. The question asks, what is the most common inheritance pattern of Goldenhar syndrome? Option A, autosomal dominant with complete penetrance. Option B, sporadic occurrence with low recurrence risk. Option C, X-linked recessive inheritance. Option D, mitochondrial inheritance. The correct answer is B. The majority of Goldenhar syndrome cases are sporadic occurrences. Recurrence risk for subsequent pregnancies is approximately 2 to 3%. Rare familial cases suggest possible autosomal dominant inheritance pattern. Multiple genetic and environmental factors are implicated in disease etiology, making prediction challenging. A newborn with suspected Goldenhar syndrome requires comprehensive evaluation. The question asks, which imaging study is essential for initial assessment? Option A, brain magnetic resonance imaging. Option B, computed tomography of temporal bones. Option C, chest radiograph. Option D, abdominal ultrasound. Consider the anatomic structures involved. The correct answer is B. Temporal bone computed tomography evaluates ear structures comprehensively. This imaging identifies oral atresia and ossicular abnormalities that characterize the syndrome. Results guide surgical planning for potential hearing restoration procedures. High-resolution imaging protocols are preferred to visualize the fine anatomic details of middle and inner ear. A 3-month-old infant with microtia requires hearing evaluation. The question asks, which hearing assessment is appropriate at this age? Option A, pure tone audiometry. Option B, auditory brainstem response testing. Option C, speech discrimination testing. Option D, tympanometry alone. Consider the patient's developmental stage. The correct answer is B. Auditory brainstem response testing is objective and age-appropriate for infants. This test does not require patient cooperation, making it ideal for young children. It identifies both conductive and sensory neural hearing loss components. Testing should be performed within the first 3 months for early intervention. A newborn with Goldenhar syndrome undergoes comprehensive systems review. The question asks, which cardiac evaluation is recommended for these patients? Option A, no cardiac screening needed. Option B, echocardiography for all patients. Option C, electrocardiogram only. Option D, cardiac catheterization. Consider associated anomalies. The correct answer is B. Cardiac defects occur in approximately 30% of Goldenhar syndrome cases. Ventricular septal defect represents the most common cardiac anomaly. Tetralogy of Fallot and coarctation of aorta are also seen. Therefore, echocardiography is recommended for all patients with Goldenhar syndrome during initial evaluation. A 6-month-old infant with confirmed Goldenhar syndrome presents for follow-up. The question asks, which renal investigation is indicated for this patient? Option A, no renal screening necessary. Option B, renal ultrasound. Option C, intravenous pyelography. Option D, renal biopsy. Think about multi-system involvement. The correct answer is B. Renal anomalies are present in 10 to 20% of Goldenhar syndrome patients. Possible findings include renal agenesis, ectopic kidney, or hydronephrosis. Renal ultrasound provides non-invasive screening for these abnormalities. Early detection through screening prevents potential renal complications and guides appropriate management strategies. Parents of an affected child ask about treatment coordination. The question is, which specialist is essential in the core treatment team for Goldenhar syndrome? Option A, dermatologist only. Option B, craniofacial surgeon. Option C, rheumatologist. Option D, oncologist. Consider the primary anatomic abnormalities requiring intervention. The correct answer is B. The craniofacial surgeon coordinates surgical reconstruction and serves as team leader. The multidisciplinary team includes plastic surgeon, otolaryngologist, ophthalmologist, audiologist, speech therapist, and geneticist. Management requires a staged surgical approach spanning throughout childhood to address evolving needs as growth progresses. A 1-year-old child with bilateral conductive hearing loss requires intervention. The question asks, which hearing intervention is most appropriate initially? Option A, cochlear implantation. Option B, bone-anchored hearing aid. Option C, no intervention until school age. Option D, conventional hearing aids. Consider the type of hearing loss. The correct answer is B. Bone-anchored hearing aids effectively bypass oral atresia and conductive hearing loss. These devices can be used from young age with soft band attachment. Permanent implantation becomes possible after age 5 years. Early hearing rehabilitation is essential for normal speech and language development in affected children. Parents inquire about optimal timing for facial reconstruction. The question asks, when is mandibular reconstruction typically performed in Goldenhar syndrome? Option A, immediately after birth. Option B, early childhood age 4 to 6 years. Option C, after completion of facial growth post-puberty. Option D, never indicated. The correct answer is B. Mandibular reconstruction is typically performed between ages 4 to 6 years. This timing allows adequate assessment of jaw growth patterns before intervention. Distraction osteogenesis represents the commonly used surgical technique. Multiple stage procedures may be required to achieve optimal functional and aesthetic outcomes. A 4-year-old child has a large epibulbar dermoid affecting vision. The question asks, what is the indication for dermoid excision? Option A, always removed for cosmetic reasons. Option B, visual axis obstruction or significant astigmatism. Option C, prevent malignant transformation. Option D, never removed surgically. The correct answer is B. Epibulbar dermoid excision is indicated for visual axis obstruction or significant astigmatism affecting visual development. Small asymptomatic dermoids can be safely observed without intervention. Surgical excision carries inherent risks, including corneal scarring and irregular astigmatism. Therefore, careful patient selection is essential. A newborn with severe mandibular hypoplasia experiences respiratory distress. The question asks, which airway complication requires immediate intervention? Option A, laryngomalacia. Option B, obstructive sleep apnea. Option C, acute upper airway obstruction from glossoptosis. Option D, chronic bronchitis. Consider life-threatening emergencies. The correct answer is C. Severe mandibular hypoplasia causes glossoptosis, where the tongue falls backward, obstructing the airway. This represents a life-threatening emergency requiring immediate intervention. Management may include prone positioning or nasopharyngeal airway placement. Severe refractory cases may require tracheostomy for definitive airway protection. A 3-year-old child with Goldenhar syndrome presents with significant speech delay. The question asks, which factor most contributes to speech development delays? Option A, intellectual disability alone. Option B, combined hearing loss and orofacial anomalies. Option C, visual impairment. Option D, motor dysfunction. The correct answer is B. Combined hearing loss impairs auditory input necessary for language acquisition. Orofacial anomalies affect speech articulation mechanisms. Facial nerve weakness further reduces oral motor control. These multiple factors synergistically delay speech development. Early intensive speech therapy intervention is essential to optimize communication outcomes. An infant with Goldenhar syndrome demonstrates developmental delays. The question asks, which central nervous system anomaly is associated with this syndrome? Option A, multiple sclerosis. Option B, cerebral hemiatrophy or corpus callosum agenesis. Option C, Alzheimer's disease. Option D, Parkinson's disease. Consider structural brain malformations. The correct answer is B. Brain magnetic resonance imaging is recommended for comprehensive evaluation. Cerebral hemiatrophy occurs in 10 to 15% of Goldenhar syndrome patients. Corpus callosum agenesis has also been reported. These central nervous system anomalies are associated with increased risk of intellectual disability and developmental delays. A newborn with Goldenhar syndrome presents with feeding difficulties and vomiting. The question asks, which gastrointestinal anomalies should be considered? Option A, inflammatory bowel disease. Option B, tracheoesophageal fistula or esophageal atresia. Option C, peptic ulcer disease. Option D, cholecystitis. Think about congenital anomalies. The correct answer is B. Tracheoesophageal fistula represents a reported association with Goldenhar syndrome. Esophageal atresia also occurs in some patients. Other gastrointestinal anomalies include anal atresia. These conditions require prompt recognition and early surgical intervention to prevent serious complications such as aspiration pneumonia. Prognosis in Goldenhar syndrome depends on severity and organ system involvement. Most patients have normal intelligence when brain anomalies are absent. Multiple surgical interventions can significantly improve both function and appearance. Life expectancy is normal in isolated cases. Quality of life is substantially improved with comprehensive multidisciplinary care. Thank you for watching this comprehensive review of Goldenhar syndrome. Early diagnosis and coordinated multidisciplinary intervention optimize outcomes for affected patients. Please subscribe to Pediatric Case Review for more informative presentations on pediatric conditions. If you have any questions or topics you would like covered, please leave a comment below.